the gingiva. We have to retract the gingiva, so because one of the reasons that you need to capture the margin, it's very important, it's the most critical area, and you need to capture beyond the margin, okay, which is the tooth beyond the margin to have the right emergence profile. You need to capture beyond the margin to have what we call, when you move, this is the margin, and you move beyond it and you capture this area, you get what we call the skirt, a little projection, which is the impression of the sulcus, okay, where you have placed the cord, you remove the cord, you have pushed this gingiva away using the cord, you created the space, you made the material to flow here, you produce an impression of the sulcus. When you pull it from the tooth, look, you have this projection, which is impression of the sulcus, or what we called impression flush or skirt. Why is this important? Impression, it's very important because it gives you the right emergence profile, but also when you're evaluating your impression, it makes it easier for you and for your technician. If you have a 360 flush, the technician will love you. Now, what does that mean? Why is that significant? Let's read this impression. So, this is here, the tip of the tooth in negative impression. So the bottom here is actually the impression of the incisal edge of this canine or incisor, correct? As you go upward here, this is your axial wall. And then as you come here, let's start on this one. Here, this is, you can see clearer, this is your incisal edge. This is the tooth wall, correct? Mesial, buccal, lingual walls. And then there is a little horizontal area here. See? Tooth surface, this little horizontal area. This is your tooth margin. What comes after that here, if you capture it, is the impression of your sulcus, which is it captured a little bit of the tooth and your impression of the sulcus. So you can read, look, you can read the impression easily. What does mean read impression? You have a clearer view of exactly where is your demarcation, of where exactly your margin. Everything is clear. Look at this one. Can you tell where is in this area, can you tell where is the gingiva? This is the remaining of the gingiva. This is your sulcus, like a line demarcating, and this is your margin. In this area here, you have a very poor impression of your skirt or sulcus. In this area here, when the technician pours it, or even when you are reading it, you can see that this is the tooth, this is the margin. Straight away, flat next to it is your gingiva. The technician will find it very difficult to tell where is your margin. It's going to be nearly impossible. And this is the critical area. This is your margin. This is where, if he goes beyond that, he will have a thicker margin where it's going to be, or a thinner margin where it is a faulty impression or faulty crown, and you might need to redo it. So that's why, although if the technician is clever or experienced, it might be okay, but it's not excellent like those where you have reproduced the skirt or the flush or impression of the sulcus. Now this is poor. Do you know why? What is the problem in this impression? You have captured the flush. You have captured the occlusal surface. You captured the margin. Look, the margin. But you have a big void in this area of the margin. Any void, any defect in the margin, you have to repeat the impression. Why? Even if it's a small area. Because, as we said earlier, margin is a critical area. If you don't capture it for any reason, like here, look, this is your margin, this is the flush. A flush void is not a critical, but the margin void is critical, so you have to remake it. Look at this. This is your occlusal surface of a molar, of a premolar. This is your margin, this is your flush, and this area is your margin. You have a little void in your flush or skirt. That's not a problem, because this is the sulcus, your margin is intact. So this remains an excellent impression. This is a drag. You see, there was a pull, there was an air or unsuccessful impression of your margin in this area and in this area, which is part of your margin. So you have to repeat the impression. So how do you evaluate a master impression? You should have recorded fully the margin or finish line. No voice, no folds, no problems. It is preferable to have the skirt of the flush or the sulcus impression. Axial preparation of the walls. You should hear those walls. You should have, if this void here was a tiny bit down there, it could have been acceptable, okay? Because you should have minimum void, ideally no void, but a tiny void in it, it could be okay, but not in the margin. Occlusal surface, again, minimal void can be okay, ideally should not have that. Unprepared teeth, the teeth on the adjacent teeth, let's say this is not a prepared tooth, this is the prep tooth. Even though here there is a drag, it's not a big problem, this is a big issue. So impression should be well supported in the custom tray or your impression tray. So again, when do we retract the gingiva? We said it's very important to retract the gingiva because you need to capture the margin and to capture beyond the margin and to be able to have a better reading and evaluation of your impression. So when do we retract the gingiva? During teeth preparation, it makes your life much easier to move the gingiva away to have a drier area and to have a better view and contrast. As we said, during the impression making, it's the most important time when you need to retract the gingiva. 3 criteria you have to satisfy when you're using a gingival retraction material. So there are a couple of techniques of gingival retraction. You need mechanical retraction or mechanical chemical retraction or surgical retraction. Any of them, they have to be effective. You should not have systematic effects, and they should make the gingiva heal and have no irreversible damage to the gingiva. So after impression, everything, even if it takes a day or two, gingiva goes back to the position. What do we mean by mechanical retraction? So you can use a cord only and put it in the here, and you push mechanically the tissue, and that's called mechanical. Old technique, it's historical. You can use copper band and you put it this way, which pushes away the gingiva, and you fill it with impression material. Now if you add hemostatic agent to this cord, so this material, hemostatic agent, will have a chemical effect where it will shrink the gingiva and make it smaller in size, so it will push it away because of that, and that's a chemical. And the presence of the cord itself will push again mechanical. So chemomechanical is using retraction. It's one of example is retraction cord with hemostatic agent. Also retraction paste with hemostatic agent is another example. Surgical. So gingival retraction technique surgically, this is an example of the paste, by the way. Surgical is, for example, using electrosurgery like this. It's basically, as we said, retraction is pushing away the gingiva so you can expose the margin because you want to capture this area. So simply, if you cut this area, you actually exposed it. So electrosurgery retraction is not a retraction, you're actually cutting away and it will heal. You can use electrosurgery machine, you can use laser, you can actually use what we call the burr, which is what we call the gingitage or a curettage. You use the burr and you cut away the gingiva and you expose the margin. Electrosurgery, you basically used controlled tissue destruction by removing the gingiva. There are a couple of electrode tips. It has 2 sides, one to cut and one to stop bleeding. You have to use it. It's a very It needs a very steady hands. You should not touch the tooth or bone because that can cause destruction. The tissue has to be, the patient must be grounded because you have to put this at the back of the patient. You have to move your hand quickly, and you should never stop moving. It has many advantages. It clears the area and stop the bleeding. But it have very bad odor, and it can cause bone destruction if it was held or used incorrectly. People with pacemaker, you should never use it. It's an electric device, so you can stop the pacemaker. In fact, patient obviously have to be warned about it's like a barbecue smell, and you have to warn him about that. It has to be very numb, and you have to have continuous movement, which can be tricky. Gingival retraction cord. So as we said, you are mechanically pushing the gingiva away in order to make room, or make the sulcus bigger, and pushing the gingiva away. And you can use a cord, okay, to flare the gingival sulcus. Just using the cord without it having any chemical solution in it will push the gingiva away. If the gingiva is not healthy, by doing this, it will immediately bleed. So that's one of the most important reasons why, because you're going to be using cords when you make an impression, so the gingiva has to be healthy. That's why before the impression, you have to tell the patient to get that area very cleaned, healthy, no plaque, so no inflammation, and use mouthwash. So gingival retraction with the cord and with chemically, you take the cord and you impregnate it in retraction paste, will give you the effect of mechanical-chemical method of displacement. Now, in Ajman University, you should not use a plastic periodontal probe to pack your cord. Please, the right way of using it, either to buy an instrument called packer, gingival cord packer, or use a plastic instrument, the one that we use for composite application. But do not use a periodontal probe, please, because that is too sharp and it will poke the gingiva for bleeding, which we do not want to do. So the cords, as you know, they can be classified by configuration, twisted, braided, knitted, or by number of strands. You can place one cord or double cord packing. They can be different in thickness, from 000, which is the tiniest, to 3, which is the biggest. So the most commonly used here usually is 00 and 0, or 000 and 0. You put always the smallest one first and then a bigger one if you're going to do double cord technique. Also, they can be plain or impregnated, as we said. Now, the medicaments. What are you gonna apply into the cord? What are you gonna use as a hemostatic agent to have the chemical effect of gingival retraction? So basically, you wanna shrink them in size and make them non-bleeding. To do that, you can use either vasoconstrictor by removing the edema in them, or astringents. Now, the mechanism of vasoconstrictor and mechanism of astringents are different, but basically they both will shrink the size of the gingiva and make them smaller. When you have that, you will have a gingiva that goes far away from the tooth, because it becomes smaller in size. Now, hemostatic agents, some of them are epinephrine. Now, this is a full table of the most commonly used: epinephrine, alum or aluminum chloride, ferric sulfate, or tannic acid. Now, epinephrine, a note for you to know is that we no longer use it. The reason is, even that it's a solution that you put it on the sulcus, it still can seep into the the whole body and cause a systematic effect, okay? And it can cause a lot of problems and a systematic reaction and epinephrine syndrome. Now, ferric sulfate, which is the viscostat brown, okay, is very acidic. It gives a beautiful gingival retraction and for a longer duration, but it causes two problems. It's brown, it can cause yellow discoloration, and it's more acidic and it can cause damage. So it shouldn't stay in the sulcus long enough, very long, or it will cause gingival irreversible damage. Now, the one we usually use here in Ajman University is the Viscostat Clear, which is the aluminum chloride, which is very widely used. It is not very irritant. It's a very good hemostatic agent. It's less potent than the Viscostat brown, okay? But it does the job when you're doing 1 or 2 crowns, if it's used correctly. It's also in the Expasil or the gels. This is a list of the others where you can see or read the advantages and disadvantages of the most commonly used, except, as I said, epinephrine. We don't use it any longer or advocate its use because it's not safe. Now, mechanical-chemical is the gold standard. So basically, it's the use of a cord or cords which are impregnated. So the mechanical is the use of the actual cord, and chemical is the use of the hemostatic agent inside the cord. Now, this is the gold standard, meaning when you are doing a crown impression, if you have a subgingival gingival margin or equigingival, you need to capture this area, which is beyond the gingiva. So you need to get the gingiva away, make the sulcus bigger, and the best or the easiest and the quickest and cheapest technique would be the gold standard, which is the use of the cord with the hemostatic agent. So you need to learn this technique because you will be using it very frequent in your daily practice, inshallah. So there is either placing 1 cord or 2 cords and sometimes 3 cords. 2 cords is the advisable and the most predictable technique, so I'm going to teach you that. It's very good for someone who has slightly unhealthy gingiva, or when you're having multiple, because you want the gingiva to be retracted more and the sulcus to be dry and big. How do you do cord packing? So this is just some clinical tips. There is you cut a fairly long cord, you impregnate it with a hemostatic agent, you loop. This is the looping technique. So you cut it long so that you can hold the 2 ends at this side, and you run it around, and then you press with a plastic instrument this way, and you don't go vertical, you go towards the root, and you place the plastic instrument here and here, one at a time. You place it and you press it here, and you pull on the strings at the ends here and here. This effect, because the tooth is bulbous, this effect will get the cord in 1, 2, 3 areas: distal, lingual, and mesial. There might be some few areas remaining, and you just need to tuck it in, and all what's remaining after that would be the buccal. So it is an easy technique where you would loop the tooth with the cord, and you just press here with the plastic instrument or the cord packing instrument. So you will stabilize the cord in this area, and when you pull the string here, all this area will go inside, because basically the tooth is narrower underneath this area, and you're pulling it while you're stabilizing it here. The same, you place the instrument here and then you pull. So you will have the cord packed here, there, and here, and all what's remaining is here and there, and sometimes some other areas, and you could just review them. if you're going to pack it systematically, make sure that you are packing from an area which is already packed, and then you move to an area which is not packed. Because if you pack this area and not like walking from a packed area, it will jump, it bounce back. You will notice this. So always when you're packed, try to pack from an area which is already packed to area which is not packed. It will make your life way easier. Okay, and try to point it to an area which is already packed. Then you cut. This would be too long. Cut the excess, and you can then lie them on top of each other, or just get the two ends to meet. So the direction of the instrument is always toward the packed area, because if you do it in an area which is not packed and in the other direction, it will bounce off. Now, so the double chord technique, you start with a smaller, so either 000 or 00. In my experience, 00 is usually a very good one. As small as sulcus, you can go with 000, is placed below the finish line. This chord, important thing is that it's sealed and it dries, because it's reduced the flow of the sulcular fluids. So here, it's usually very dark. It gives you a good demarcation, and you can see the junction between the two, because sometimes it can be very distracting. So this is your first chord. It stops the circular fluid, and then you take the second chord. Both of them, you can impregnate them and place it over the small chord. So always, the smaller chord is the inside chord. Look, the smaller chord is the inside chord. The bigger chord is on top, and it has more function to open the sulcus for you. So the second chord, the first chord has to be completely inside. The second chord either inside fully or partially inside. The second chord, when you leave it in place for 3 to 5 minutes, depending on the manufacturer instruction of the hemostatic agent. Some of the hemostatic agent you have to leave them longer, some of them you have to leave them shorter duration. So when you come to the impression taking time, so this is the second chord, you need to remove the second chord slowly and gently. Why slowly and gently? So you do not pull it fast and you remove some of the epithelial tissue and induce bleeding. You need to be very gentle. Okay, then you need to assess, there is no bleeding, is the sulcus open, and then you leave the second chord in and you immediately start your impression making. And then once your impression is done, you can remove the black or first chord. So look carefully. When you look, this is the second chord. Once you remove the second chord, please, you have to do your check. What are the checks? Number one, you see that you effectively have produced the aim of placing this chord, which is, you can see an open sulcus. Look, you can see an open sulcus, which is ready for the impression. You have widened and flared your sulcus. 1. 2, that your second chord is fully in and it doesn't come out on top of your margin, so that will cause the distortion. Number 3, there is no bleeding. Number 4, with the 3-in-1, you have dried the area and there is no sulcular fluid, and everything is dry, and you can inject your material inside your opened dry sulcus. This is a beautiful image showing you exactly that your prior to putting the impression, you have effectively expanded the impression. Now you have to leave this in place before removing for 5, as I said, 3 to 10 minutes according to your manufacturer. You have to wait, because there is not only mechanical pushing but also chemical effect of shrinking, so you have to wait. When you put the first chord, it's a very good idea to it will give you some pushing, and you can do final finishing of your margin. So how to make the impression? As you know, and you have taken in third year, you can do it physically with impression material, or digitally with an intraoral scanner. With an actual impression material, you have a couple of the ones we usually use in Ajman University is PVS, or addition silicone, polyvinyl silicosane. It comes in different viscosities. Again, polyether or the Imprigam is also available. These are not usually used. Has not a good taste. It can shrink. It has to be poured within an hour. After an hour, this one is very stiff. It's not great in it's not stable, because it can have some condensation byproducts of water. So by alcohol evaporation. So the most commonly and most accurately to be used are those two, PVS and polyether. Now, polyether, newer ones, are slightly hydrophilic. They are more loving to water, so they are a bit have that slight advantage of addition silicone. But are they fully hydrophilic? No. So you still have to do the same. Everything has to be dry. So they are relatively hydrophilic. Now, impression technique with the impression. So there are a couple of techniques. Putty wash, where you would do one stage. You put the putty in the tray and wash in the patient mouth, and then you impress, and it's one impression. Two stage, as you have been taught previously, where you would put a spacer and make a putty impression, and this can be done on the cast to save time. The spacer, if there is no spacer, you scrape it with a blade, and then you make a second impression after this sets using light body. Monophase is using one impression material, which is not light and putty. It's one phase. It's usually medium putty, and it is one material. There is no two viscosities, and it's available in polyether, like this image, or as well in PVS. Other techniques. This is an image of the matrix impression technique. You make a matrix, okay, and you impress it. And we talked about the copper band impression techniques. Now, these are not common. The common are the monophase and the putty wash techniques. So those three techniques are the common. In digital, you already have studied this in details using the intraoral scanner, which we can use if you want to do it in the clinics. Now, let's talk about actual steps of how to make an impression. So the dental impression, you need to make sure that everyone is in sync, everyone knows what they need to be doing. You don't want to practice when you're doing the impression. Everything has to be practiced before impression. All the materials are prepared and ready. For example, the trays already have been made and painted with adhesive. You have already bleed the cartridge, and the tips are already in place and ready to be used. Patient is in supine or near supine, as I was telling you, so that you can see and visualize everything. You have the patient seated. Don't do the impression when you are standing, because you don't have the right dexterity and manual skills to do that easily. And you have full access while you are seated for all the instrument and the material. Do not use latex material, because PVS, if you're using PVS, can be having inhibit the setting of PVS setting can be inhibited by the sulfur in latex, so avoid using latex if you're using, or ask the assistant or partner of you to mix the putty with either bare hands or disinfected or with non-latex gloves. Soft tissue retraction. After that, make sure that you have improved the visibility and you have retracted the cheeks, tongue, and lips by using cheek retractors, either the metal ones. You can buy them. They are you can sterilize them, make the patient use them. You're making your dentistry six-handed, and you're using the spare hands of the patient, who can be distracted by that and very helpful in doing that. Gingival displacement. Make sure that you have placed your mechanical-chemical double cord technique, which with the cords being double and impregnated, and keep them for the right duration as we talked and described by the manufacturer. And once you have done the soft tissue retraction, gingival displacement, everything is ready. You are going to keep the area dry by placing dry tips, as we talked about, on the cheek. You can, or if you don't have them, you can put just cotton rolls bilaterally on the next to the parotid gland ducts. If you're doing a lower impression, that's for the upper impression. If you're doing a lower impression, you still place them on the upper buccal sulcuses for the parotid glands, and also you put some cotton rolls in the mandible next to the teeth. Add more cotton rolls, as I said, for the mandible. Use the suction tips. You can tilt the patient's head to the right or left, so that you may if you're working on a right side tooth, you can bend the patient's mouth to the left so the water pools away from using gravity to that direction, and keep the ejector on that area. Then let's start by, then we have everything in control. You can see everything. We have waited to the right duration and the cord has been placed fully, the two cords inside. Now we're going to do the impression. To do that, you are going to remove, as I said, the first, this is placement of the two cord, removal of the first cord gently and slowly so it doesn't tear any cells. And once you do that, everything has to be worked out very quickly because the sulcus can collapse. So you have few seconds actually from there on, so you have to work very quickly. So once you remove this, you have to do 4 checks. Number 1, check no bleeding. Number 2, check that the second cord is fully inside. 3, that your sulcus is open. And then number 4, you take your 3-in-1. Look how open is the beautiful the sulcus, and then you take your 3-in-1 tip and you dry. I would always recommend that you keep drying before removing the cord, and once you remove the cord, for another 10 seconds, go around, dry. Once this area is dry, look how beautiful and dry and everything is here. Only you have those 4 checks, you can start impression. How do you start the impression? You start your impression from the distolingual area, because it's not easy one. You keep the tip, you bleed the tip a bit outside the patient's mouth, make sure you have a nice mix, and then you put it in the distolingual area and you get it to flow. You don't move until there is a bit, see, it's still in the distolingual. You see a bit of flow, and then you move. Always there is some material ahead of you and you are moving. You move slow, okay, and you press hard so the material, there is good flow in it. You move slow, so distolingual, distal, buccal, and you keep moving always ahead of you, and then mesial, and you can see, that's why you need to be seated, and then mesial going to the lingual, to the end of the lingual, and then you have done all your margin all the way, and then move slowly and press hard, okay, and then always keep the syringe tip in impression. Never go fast, otherwise you will if you go fast ahead of your impression, you will introduce bubbles, and that will give you a void, and then you repeat the impression. Continue all around. Once you did all your margin, you have here only placed the impression in the most critical area, which is the margin. Once you do that, now you will continue like a ice cream all around, like that. And you move up, always some material ahead of you. Once you have done that, you need to place some material on the occlusal surface of all the remaining teeth. This is using your light body or regular body. Then you load your tray, whichever tray is, okay, and either your putty, if you're doing a one technique, or your spaced impression or your special tray. This picture means you do not overfill. If you overfill, you will have so much of light body going to the patient's throat. You just need to make one line of light body, a U shape, and that's it. Don't overfill. Now, so to avoid overflow backward, you can dam by using some wax at the back, at the heel of the tray. Seat the tray into the patient mouth with posterior area first and anterior, and slowly, so everything does not overflow to the patient back, the patient throat, and you introduce a gag reflex. Go slowly so the material flows forward or anteriorly. Now, keep and hold. Don't push, just hold it for 5 full minutes, because if you're, as we said, the materials you're going to be using, the 4 materials you're going to be using, most of them have 5 minutes, except the polysulfate we don't really use, but polyether and PVS, you have their setting time is 5 minutes. So don't touch the material and say, oh, it's set. No, it didn't set fully. You have to wait full 5 minutes. Do not remove it before full 5 minutes. Wait for that. So once you seat it in, ask your partner to check the time, and you count. Once it's set, it's stiff. Most of them, they're stiff. What you need to do to remove them, you need to release them. Place your finger at the distal buccal corner, one finger here. This will push this down, and one finger here to push the handle upward. So basically you are flipping down, up, flipping the tray. This way you release it very quickly and easily. So once you remove the first cord, the sulcus is open, it's dry, effectively placing the material, and once it fills this area, this is how you remove the cord, and you introduce into the open sulcus after drying it, and then you place your tray with a spacer or with a putty. You put it in for 5 minutes and you remove it. Then you have to, this is your have to have the things you need to, it's not only the impression, but you need your impression and you disinfect it. You need to take a opposite arch impression, or probably you have ready-made study cast. These are the things that you need in hand to send to the technician. So you have to have all these records: the master impression, opposing arch, interocclusal record, and you need to put it on the prepared tooth. So before you cement the temporary crown, and a lab docket with all the information: what is the crown material, what is the tooth has been prepared, what is the shade, and what is, if you have any photograph, etc. Before dismissing your patient, make sure that you have cemented the temporary crown and remove all the excess. Remove the second cord, don't forget their second cord, and make sure that you have a good temporary crown. Give the patient instruction: do not eat for 1 hour, do not eat you do not eat on the operating site for 24 hours, avoid sticky food, maintain good oral hygiene. Temporary crown can come off, please don't panic, just contact the dentist. So we have done all these. You send the patient, you send the lab the prosthesis for the fabrication of the lab for the fabrication of the prosthesis. This can be in any technique. Usually it takes 1 or 2 weeks. They will give back you the crown where you're gonna fit it. On the day of the fit, you are gonna have to inspect the crown on the cast, and this should be evaluated before cementing. The restoration should be checked first on the die, make sure it fits nicely, make sure that you have removed, this is one of the ways you have removed the temporary crown. You can use a temporary crown remover, you can use a removing plier. If it's too tight, don't force it. You can break the core, you can break the tooth. If it's too tight, cut through it gently and sacrifice the temporary crown. It's important the tooth, not the temporary crown. Remove the temporary cement because it can prevent the full seating of your crown, and polish the tooth. You have to try the crown, and there is a sequence. You have to go in this sequence, otherwise it can go wrong. So the number one is the proximal contact. The most common reason for crown being unseated is tight proximal contact. Now, look carefully. The technician has to remove a tiny bit from the adjacent tooth in order to make the contact here tighter, or because if they don't do that, you might end up with an open contact because the tooth has a tiny mobility in it. So what do? They produce a crown which is slightly over contoured. Now the right technician, or the excellent technician who knows how to produce a tiny contact which is just right enough that you have a positive contact without you doing any adjustment, and you have a successful contact. But the reason why, because not all of the technicians are able to do this successfully, they produce a bigger contact here proximally, here between the teeth. This is the crown, so it's wider on the side, and it is bigger on the side that it prevents seating. Okay, and that's the reason why if you have a crown, it's not seating well, or you have an open contact, the most common reason is that you have tight proximal contact, so over contoured proximally, and it's too tight proximal that it doesn't seat. So tight proximal contact, the crown will be unseated, you will have open margin, and the crown will be in a state of false hyperocclusion. It's high. So do not, for this reason, it's very important that you never touch or adjust the occlusion before checking the proximal contact. Because then if you do that and then you remove the proximal contact, the tooth, you will lose all the occlusional right contacts. So check the contact with a floss. How do you check if the problem is proximal? You need to check it either with a floss or thin articulating paper while pressure is maintained. So you place the temporary crown, you get your assistant to hold and press on the crown while you're passing on a floss. If the floss doesn't go down, okay, with normal pressure, then this area is too tight. Or you place a tiny piece you cut your articulating paper as a small piece, and you place it as such on the side. You push the crown in, you hold it with a plier and pull. If it tears off, okay, it means this area is too tight and you need to adjust it. And the advantage of this is that it will also mark the tight area. So check the contact with articulating paper, make sure that the assistant is holding it well in place, and once you mark it with an indicator, which could be, as I said, a thin coating of pressure indicating spray or red pencil, or as I said, a thin articulating paper, then you can remove it. Now you have one of a couple of options. Either you have a tight contact or light or absent contact. So if you have a tight contact, we said you will not seat. Patient might have pain, and most importantly, it will have an open margin where you can have caries. Adjustment, you mark it, remove it, and you polish the area. If you have a light or absent contact, food can get impacted, gingival irritation, and you will have caries. This is a big problem, because this you can adjust it here in chair side, but if you have light or absent contact, you need to send it for the lab. They will add porcelain for the ceramic crown or solder for metal and re-establish the proximal contact. So this is very important. No, as I said, This is how the first check is in sequence of trying is proximal contact. How do you check it? With a floss or articulating paper. If it's too tight, which is the usual consequence, you adjust it with a diamond, polishing burr, or a cylindrical stone, white stone or green stone, and you then have to use a ceramic polishing burr. Usually in Ajman University, the students don't have it. It's very handy once to have them as an undergrad, or once you become, you have your own, you work in your own practice, because then you don't need to send, once you remove any, either occlusally or proximally from the ceramic, or touch it with a burr, you have to get it back to the glaze state. To do that, either you put it in the furnace, or more easily just polish it with a ceramic polishing burr. So you just simply buy them and have them handy with you, instead of sending, it's a 5-minute job, save you to send the crown back to the crown. So just get a ceramic polishing kit. Now, number 1 is proximal contact. Number 2, now the crown goes in fully. You need to make sure that there is all the margin. This is the crown, this is the margin, this is the tooth. There is no marginal discrepancy. It fits flush, no gap. There are a couple of discrepancy. Now, the gaps, it could be, look, horizontal discrepancy. So it could be fitting vertically correct, no gaps, but there is hypocontour or overcontour. And as we said, this is a problem if you don't give them the right emergence profile. Here, if there is a discrepancy, you adjusted the contact, but the lab you still have a gap. So in this case, this is the worst type of marginal discrepancy. You basically have a gap at your margin. You just send it to the lab, or you have, this is, we call it horizontal positive, horizontal negative, vertical positive, vertical negative, vertical positive. For this one, you basically ask the technician to cut this area back and polish it. Here, you can ask the technician to add more ceramic, and you sort it out. Here, again, you can cut this back and polish it. Here, you have to repeat the crown or the impression, because usually the reason why they produced it this way, they didn't have the right impression. So this is the worst in consequence and in fixing. So you have to check. So marginal integrity, how do you check this? You have to make sure that this is flush. Flush fit means edge to edge, crown edge to abutment edge. So to do this, you need to check it with a dry fit check. Means the assistant has to apply air here, and you check visually that this crown and this tooth, they are coming next to each other flush, edge to edge. Now, this is, you need also to check it by tactile. Sharp Explorer, you pass it this way and it doesn't sink in as you have, or you have this ledge. So if the margin is open, you need to check it in the die. If it's open in the die, it's an easy fix, because you just ask the technician to add some ceramic. If not, you have to actually repeat the impression. Now, stability. So number 1, you check the proximal contact. 2, you check the marginal contact or integrity. 3, you check that there is no rocking. If there is rocking, check if there is no any problem or nodule, and you can remove that. The number 4, everyone checks occlusion first, and here occlusion comes number 4. As I said, if you check the occlusion in the beginning and there was problem in the fitting, then you will lose all the occlusion contacts. So do not check occlusion as number 1. You need to make sure the occlusion is checked after that you have checked that the margins are fit and the proximal contacts are correct. Now, how do you check the occlusion? You check the occlusion again. Everyone checks the occlusion with the crown in, wrong. You check the occlusion with the crown not in. You check the occlusion without the crown. So here, you check until you find one contact behind or distal to the prep tooth and anterior. Until you find a contact here and a contact there, you record those contact by feel, pull off the articulating paper or shim stock. Then you have one of three, put the crown. If you have, and once you put the crown here, you have three possibilities. Then again, you put the articulating paper here and there. If you have a contact here and contact there, then you put articulating paper here and no contact, it means this crown is in hypoocclusion. And in this case, you need to send it to the lab. They will add some ceramic and you can cement it back only after that. Now, if you have no contact here and no contact here and only contact here, it means that the crown is in hyperocclusion and you need to adjust, remove this until this tooth and this tooth are back to their original contacts. But you need to make sure and that you are measuring it with a I1 because you don't want it to be less than the occlusal thickness that you have created. Otherwise, you have to re-prep more space and take a new impression. Otherwise, it will break. The third possibility, you put the crown in, you find that you have a contact here and a contact here, just like before the placement of the crown, and the contact here. It means that the crown you have fabricated is in the right occlusion as with the others, and this is what you need to reach. So if it's high up here, you remove until it's up to that. If it's low like this, you need to add ceramic, send it to the lab to add ceramic until it's touching back here as with the neighboring teeth. You number 5, you check that the shade and aesthetic, make sure that everything is nice. You give the patient and the co-patient, make sure that they give you an approval, and you tell them once you cemented this is final, there is no go back, they have to give you the thumbs up and the green light to submit to cement it. If the shade is lighter, it can be darkened in the lab with external stain. Again, that's a 45 minutes adjustment that you can send. If the shade is darker, it's not easy to, and it's sometimes usually you will need to send it back for remaking. Cementing the crown, this is you will be taking with Dr. Rohit. He will talk more in details about it. You just have to make sure that you have to adjust to follow the instruction of the manufacturer. Make sure that you have placed and removed the right amount of cement, and that you have removed all the excess cement before you dismiss the patient. Thank you very much for attending this flipped class lecture, and I hope it was a successful technique of doing the lecture. I would love to have some feedbacks on how we did it, and if there is any, we will discuss more in the class, obviously, and we will take it from there. Thank you very much.